All right, good evening and welcome to the SADA webinar with Henry Schein and GC. My name is Almin Greiling and I'm the Inland Sales Manager for Henry Schein Dental Warehouse. I am incredibly proud to be part of this Fortune 500 company with a presence in 32 countries. So here in South Africa, our ultimate goal is to become the one-stop shop for all of your dental needs. Please remember that our online store is now live, so please visit at www.henryschein.co.za. So before we get started, I just want to jump into some housekeeping for the evening. First off, if you can please refrain from using the raised hand, please use the Q&A boxes for any questions. CPD certificates will be available on the SADA platform under your profile. If you do not have a profile, you can create a member profile and then access your CPD certificate. The event for tonight qualifies for 1 clinical CEU. We are streaming live on YouTube, so if you're having any trouble with the Zoom platform, you're welcome to join on YouTube. Then just a reminder of upcoming events for SADA, if you can pencil that into your diaries. We've got the SADA Dental and Oral Health Virtual Congress that's happening on the 27th to the 29th of August. The registration lines open on the 1st of July. Then the 22nd of June with Dr. Yusuf Yadwat, the periodontal patient. The 24th of June, Dr. Barry Raphael from the US. Why wait? It is too late. And the 29th of June with Dr. Ismail Mohapi, impact of fraud, waste and abuse on medical schemes. So please pencil that into your diaries. Then without further ado, I'm going to give over to Mr. Terry Greiling from GC to introduce the speaker for tonight. Terry, the floor is yours.
Good evening. Welcome, everybody. It gives me great pleasure to introduce my personal dentist, Dr. Mark Bose. Mark is the owner and clinical director of Enamel, Restorative and Cosmetic Dentistry, a private practice in Cape Town. His practice is limited to aesthetic and complex restorative dentistry. Mark has been a fellow of the International Congress of Oral Implantology since 1997, and is also a speaker for the ITI. In 2010, he founded the South African Academy of Aesthetic Dentistry, for which he is now past president. He was also the Congress president for the World International Federation of Aesthetic Dentistry, IFED for short, which was a great success at the Cape Town Convention Center in 2015. In 2018, Mark founded the Digital Dentistry Society of South Africa, for which he is president. Mark has pioneered the development of digital smile design in South Africa, and this concept allows dentists to develop smile designs for the individual patient in a minimal invasive way that fits the patient's aesthetic and functional needs. Mark recently has been invited to be a silver member of the prestigious Style Italiano organization, and he's an ambassador for the slow dentistry movement. He's also ambassador for other organizations as well. And Mark has lectured extensively in Southern Africa and internationally. I don't know how he manages to fit it all in, but he does. And so without further ado, I'd like to hand over to Mark, and I'd also like to thank the audience for the fantastic support that you've given to our agents, both on the lab side and on the surgery side. We've reached our target even in the COVID year, and we thank you all for your support of GC products. And our support from Henry Schein Dental Warehouse has been fantastic as well over the past 4 years. And we now start our 5th year together as GC factory rep, for which I'm very, very proud to be their rep for Southern Africa. Thanks very much.
Thanks, Terry. That's very kind, very nice words that you've said for me. I'm going to share my screen and get stuck into it. Just let me know if you don't see what we need to see. Is that looking good?
Yes.
We're all good, huh?
Yeah.
All right. So, yeah, first of all, I'd like to say thank you to Sada for giving this opportunity to me. Thank you to Henry Schein and GC for allowing me to share my experiences on something that really has become an exciting component of what Terry described the dentistry we do, which is aesthetic and complex reconstructive cases at Enamel in Cape Town. Injection molding is relatively new. And if we look at some of everyday objects that are made from injection molding, we find most of our components for our computers and screens. We find most of the interiors, even for really expensive luxury cars, that come from injection molding techniques. Just about all our electrical plugs and sockets in our houses, practices, and wherever we might find ourselves every day. All, if not all, but the vast majority of children's toys, and last but not least, a lot of our dental equipment. And so, you know, if we look at the exposure of injection molding, you know, in an everyday world that we live in, I kind of feel that it's no surprise that it's found its way at long last into dentistry. So if we look at what's new in dentistry, certainly the things that are changing the face of how we practice and how our patients get treated. And most of the time, often we don't even realize, but artificial intelligence is certainly playing a bigger role in decision-making for us. There's no question over the last decade, and certainly the last 5 years, monolithic materials have got better and better and provide us much more simple solutions. And of course, something which we'll highlight, which really excites me, is the concept of copy and paste dentistry. But that's new. But what's really important in aesthetic and reconstructive dentistry is primarily that the results we give our patients are completely facially driven dentistry. And that the planning that we have access to initially starts with a 2D plan followed by a 3D plan. You know, and I'll say it now that all the cases we're going to see, and I'm going to try to keep this lecture to a much more kind of case-driven, experience-driven lecture, and show you as many cases as I can get through, and just to show you how neatly injection molding fits into our practice. But the 3D plan has become an integral part of even simple and complex cases. And what I love about it is that, you know, before, when we made mistakes, and let's be honest, in dentistry, it's possible to make mistakes, but now more and more, if not all the time, we're making our mistakes on our computers in the planning phases and not on our patients. Of course, occlusion is super important. And of course, these days, our patients expect that all concepts, all treatments are minimally invasive. But what's most important is that we provide our patients with patient-driven dentistry. And when I mean patient-driven dentistry, I mean that not only do we tick the usual boxes, which are making sure that it's aesthetic, we're making sure that the function is addressed and that it's biologically orientated. But the fourth element is obviously that we have to understand about financial needs of our patients more and more, and fit into those categories much more than maybe we did in the past. So why injection molding? Why has injection molding become really a hot topic, and certainly something that we're integrating more and more at Enamel? Is because it allows us to be conservative, and sometimes completely conservative. In other words, you know, the most minimally invasive dentistry is no tooth reduction at all. I've already highlighted the importance of facially driven dentistry, but what really appeals to me is the use of being able to integrate injection molding into the complete digital planning that goes on for all our cases. And with digital planning, it allows clinical control. And what we mean here is that all our cases become guided. In other words, the mistakes or the treatment is completed on the computer. The results are exactly as we want, and the treatment, regardless of whether it's implants, restorative orthodontics, is guided by the 3D plan. We've talked a little bit already about affordable dentistry, and I think, obviously in modern times, we have to address this because not every patient has endless finances. And most importantly, I think one of the attractive things is the ease of maintenance of composite restorations versus indirect ceramic restorations, which if they fail, they need replacement, whereas composite, as we all know, is very simple to repair. So planning, with the latest digital technology that we have in our practices, in all honesty, and I firmly believe this, we never lose control of our case. In other words, we start with the end in mind, and we absolutely reach that end goal, which is exactly what was planned in the 3D plan. So let's go straight into the first case of injection molding, and it was an ortho case for missing canines, and I seem to get a lot of these. The patient presented. The first process is to digitize, because we're going to go through the digital planning of the case. So we digitize the patient facial, digital photographs, STL files, we scan the patient, and depending what case it is, we might also integrate a CBCT. In this case, it was a pure restorative case, so the digitization went on. From there, as I've already highlighted, we created a 2D plan. And for me, as you all know, that I'm a big fan of the DSD concepts. So we use a DSD 2D plan. From there, it goes to a 3D plan, and there's many software that will allow us to create this 3D plan, which always, as you can see from this picture, is facially driven. And then the final kind of jigsaw in the piece of the puzzle is to perform, or to carry out the clinical case, which in this case was injection molding. So the 3D plan allows us to really design with transparency. And in other words, it allows us to evaluate volumetric changes that are going to occur both in the white and pink aesthetics. And with analog techniques, this is absolutely not possible to have such transparency, to have such understanding of the changes that need to be created to achieve the most ideal aesthetic result for this case. If we look a little bit closer, we'll see the missing laterals. The canines had been moved into the laterals place, the premolars were moved into the canines, and a small gap was left behind the second premolar. The design that we came up with from the 2 and 3D design was to restore the front 8 teeth, so from centrals to second premolar. But the clinical challenges that we have, and I'll be honest that there are some clinical challenges if we look at injection molding, and one of them certainly is not so much to control the guidance or the occlusion, but certainly to control closing diastemas, because of the emergence profile of the material that comes up from the interproximal space. So these are challenges, and in this case, we decided to overcome those challenges by accommodating a mix of different monolithic materials. And here we were going to restore the front 4 teeth, which were the centrals and the canines, with injection molding, and combine that with monolithic ceramics Emax restorations on the 2 premolars, making one into a canine, and the other into, it was just actually an aesthetic change for that tooth. And the reason we chose the ceramic, because it was easier to create these emergence profiles in closing that diastema, and I felt that possibly the guidance was going to be more long-term and stronger as a ceramic material, but that certainly wouldn't be necessarily the case in most of cases if there hadn't been the small diastema. So what I love about injection molding is it fits and slots right into the complete digital workflow. So whether we're providing CAD/CAM indirect restorations, or we're utilizing digital direct restorations in the injection molding technique, the workflow really allows the adaptation of both indirect and direct with the same design. So from the mock-up, once the patient has accepted these aesthetic and functional changes, we create the working 3D models for the injection molding process. And from what you can see here, given that we were doing the 4 anterior restorations, we require 2 models to come from, or 2 designs to come back from the lab from there, which we will print from the STL files, 2 models. And on the left, we have the first model, which has the alternate teeth. And on the second, on the right, we have all 4 teeth in the final model. So from that, we can see the difference. And if we look at this, the difference of detail between a conventional analog wax up versus a digital 3D design. And in all honesty, the difference is brutal in that if this was a wax up, you would not see such beautiful margins, you would not see such clear interproximal areas. And I think that inevitably what we see is often wax in places that we don't want wax. And so if we're using wax, the risk is that you're going to get material where you don't need it. So the process of injection molding, I think, from my perspective, should really be limited to a complete digital workflow and really be careful. And I certainly wouldn't use analog wax ups for the procedure. So from here, we take the 2 models and we create 2 silicon stents. And for me, the material of choice is Exoclear from GC. The reason I love it is because of all the silicon indexes, it's the only one that is completely clear, transparent. And the reason I like this is not just because that it's easier to get our light curing through to the material, but it allows you to evaluate that the index is seated, and then when we've injected, that the material is completely injected into the area that we're trying to fill. All the other indexes that are on the market have different types of opacities that don't allow you to monitor and determine these 2 really important factors. So we create these 2 indexes. From here, you'll see the small black marks that I've created to give me a guide as to which teeth we're going to inject on these 2 models, because we're going to inject the alternate teeth. So for the first model, we then take an old burr that I would normally have thrown away. You can see these coarse grit type diamonds with a tapered diamond. And I run it in a red handpiece. Otherwise, the fast handpiece goes a little bit too quickly and it starts to melt the material. But what's really important is that the access of the tip comes to the surface that we're trying to inject. So you can see in this case, we're injecting the buccal surfaces. So the access hole comes just to the buccal on the incisal area of these 2 teeth. And what's interesting is it looks like there are a huge amount of bubbles, but those bubbles actually are just in the material, not on the fitting surface. And if you want to get rid of those bubbles, it's possible to put this in a pressure curer in your labs, and it'll come up without. But these bubbles, honestly, I can tell you don't make any or don't have any impact on the final outcome. So if we're talking about materials, and there are a number of materials on the market, what's important to me is that we have a material that has physical properties that are high. And when I talk about high, I'm really looking at flexural strength and materials that are going to stand up to wear over a period of time. Secondly, we need radio opacity, and I think most composites are really adequate in this department. We need really good color options, in as much as monolithic ceramic materials have been around for a long time now, and we have many different options in opacity and translucency. If we look at Emax, for instance, we need the same range of options in a monolithic state for our composites, and we'll get a little bit into that in a while. We clearly need stability of color over the long term. We need materials that have low shrinkage. We need materials that have a good extrusion pressure. In other words, that have been developed for this technique, that are neither too runny or too stiff. And really, it's something that I didn't think was important, but having used a range of materials, it's hugely important. And I find that, that the product that we're going to speak about now has really the perfect extrusion and pressure to get it into the index without having to distort the index. And of course, you know, ease of finishing and polishing. I like to have to be able to polish things quickly, easily, because in dentistry, as we know, time is money. And for me, and having tried a number of materials, and I think there are materials on the market that are good, but for me, I have to say that Genial Universal Injectable, which is a product that was developed by GC specifically for injection molding, and can be used without injection molding, by the way, really ticks all the boxes that we see here. So if we look at this case, the challenges were that our substrate, and if we understand indirect restorations and EMAX, one of the biggest challenges is working on different substrate colors. And you could see that, as we know, canines are always darker, lower value in color. And here we were dealing with A4 and the centrals A2, and the patient wished to get to A1. So this was a real challenge to go from A4 to A1. If we look at the range of colors, and this is why I really like the GC product, is that as in indirect ceramic restorations, we have different options. So we have the universal injectables, in which the ranges are A1, A2, the Cs, we have a cervical, we have bleached colors. And then down in the bottom, we'll see we have 3 dentine colors. So in other words, these are slightly more opaque colors that will allow us to block substrate issues. And then, of course, we have enamel, which are more highly translucent and will allow a more kind of enamel effect, if that's what we need. And so when I came back to this case, we decided on the centrals, because the substrate color was good, to use A1 universal, but to combine it with A01, which is an opaque dentine, but in the A1 color. And so the beauty about injection molding versus, or injection molding direct versus indirect restorations, is in indirect restorations, we make the restoration and then check the result. And if it's wrong, unfortunately, we have to make another one. But injection molding, the beauty is we take the material, we cure it, and we can see the optical properties that it has before the treatment is carried out. And if necessary, we can inject these cases without any bonding agent, which is like a mock-up, and check the final outcome. But with this case, I was happy under polarized light that choosing dentine and a universal color, I was going to achieve the correct aesthetic outcome from a color point of view. Of course, the shape point of view was determined already by the 3D design. So all our cases, for all bonding, whether it's indirect or direct, is cleaned first with AquaCare 29 microns. That's a standard protocol that we have in our practice. And really what makes this product unique, and what amazed me is because, you know, when injection molding came on the market, I think that as dentists, we've been taught over the years that any flowable composite will definitely have weaker physical properties than normal syringe nano type composites. But as you see, this is not the case, that we compare the Genial universal injectable, and we're looking at flexural strength, which is the important one, with 2 really popular type nano composites, syringe composites, normal composites that we would use. And you can see that the flexural strength is actually stronger. And so this is a complete paradigm shift in flowable dentistry. The reason behind it, and this is not going to be a dental materials lecture, is that they've combined a full coverage silane coating with these really ultrafine particles, and they create a much more homogeneous mixture between the resin monomer and the ceramic pieces, which really creates the strength and other physical properties, which we'll get to later. So the process is that we take the first index. We're going to now inject the 2-3, the 1-3, and the 2-1. So we're going to use Teflon. We cover the neighboring teeth. We then go through the process of applying etch and universal bonding agent. And here I use Tetric N-Bond Universal, just by the way. We take our index that we've already pre-drilled the holes, and we seat it, and we inject. In this case, we injected OA1 dentine onto the canine and A1 universal onto the central. What's super important is to inject both teeth at not the same time, but without removing the index. Inject, extrude, withdraw the syringe until we get excess coming out the access hole, and then cure. After that, we remove the index. We remove the injection excess, which we can see on the incisal coming just to the buccal surfaces of the incisal edges. We clean interproximally, and I'll get to the tools that we use for cleaning. And then once we've cleaned everything, we check the fit of the second index. And you'll see that on the 2-1, there was a tiny little bubble, but that's not a problem because I'll be able to fill that in at the end with a little bit of the material. We then get the second index. We place seat the second index. You can see with a clear GC Exoclear that we can see right through the index to make sure that it's seated. We then inject again A1 universal on the central, A01 dentine on the canine, and then go through the same process, removing the injection index, the excess. We remove the Teflon, clean interproximally, and then we fit ceramic. So whenever I have a combination of ceramic or indirect and direct, I will always do the injection molding first and then fit the ceramic pieces or temporary restorations, if that might be the case. So the tools that we use for finishing is a 12A scalpel blade. I like the Softlex discs from 3M, Horico metal strips, the Epitex, soft strips from GC, and Eve Dicom twist polishers, just the two polishers, the coarse and the fine. And very quickly, you can see that we've now integrated 4 ceramic restorations with 4 indirect molding restorations, and we've accommodated the substrate problem using the difference between translucent and opaque injectable composites to hide the A4 substrate color of the canines and achieve the A1 result that we're trying to set out for. And so not only in the flexural strength, if we're looking at physical properties of this in particular injectable material, what's really important is obviously how it stands up over time. And we can see again some comparable graphs on wear loss over a period of time versus normal syringe composite versus flowable composite, and how well it does. Obviously, the smaller the better. Discoloration, again, it stands up well. That's only 7 days, so I wouldn't really go on that. But my experiences, I've now had cases that are in excess of a year and a half, going on for 2 years, and they look as good as they did the day where they went. And polish retention is super important, and we can see how well, from a physical point of view, physical property point of view, these materials are really performing. And so we have to get away from this thinking that flowable is an inferior product from a physical property point of view to our standard syringe type composites. The end result, as you can see, we've really achieved a nice result, making the canines look like laterals, making the first premolars look like canines, giving them guidance, controlling the emergence profile to close that small diastema, and then the buccal corridor or the buccal volume was just the reason that we went to the second premolar. It was an affordable treatment. It was clinically controlled completely by 3D CAD/CAM type restorative processes, and most importantly, it's facially driven and affordable dentistry. So, that's a good starting point for the first case. Let's look at a full mouth rehabilitation and why would I choose injection molding in a full mouth rehabilitation? Well, quite simply, for young patients, and more in our practices, we're seeing young patients with excessive wear cases, generalized wear cases, erosion, attrition, abrasion, and the importance when we're treating young patients like this is that we want to be conservative, and also affordability, and for sure we're going to need something that's easily maintained for the first period of his life. And in a case like this, it's possible to use injection molding, to use direct materials, but to have the clinical control of the plan from our 3D plan. And to do this case, we did it completely in an additive way. In other words, there was not one bit of preparation done to his teeth other than just to smooth the small chips that we can see for instance, on the edges of his central incisors. So this was a completely additive case. There was no tooth preparation. And I believe that this really sets him up for years to come, whereby possibly at some point down the line, we might phase it into an indirect case. But at this age, definitely, direct is the option for me. And to do it direct freehand would almost be impossible, and certainly need immense clinical skills. And for sure, if I did this case, or if, I don't think I have even the skill to do it freehand, but if we did it freehand and you did it 10 times, you would get 10 different results. Whereas with digital, we're going to do it 10 times, we'll get 10 results exactly the same. So the process starts again. As you can see, it's facially driven. We start with a 2D plan. We decide on the aesthetic outcome before we start looking at increases in vertical occlusion and all the other changes that we're going to need to make for him. From there, we move the plan to a 3D plan. And in this case, you can see that we actually ended up opening the vertical. You now recognize the injection molding models that we get with alternate teeth and then with all the teeth. And from there, we're going to make our exoclear indexes. We're going to inject the alternative teeth. We're then going to take the full model, inject the remaining teeth. Same method as before, increase in the vertical, complete clinical control, guided completely by the 3D design. And I think you'll agree that we get really a beautiful aesthetic, a beautiful functional, and most importantly, a completely biological result, because there was no tooth preparation. It was affordable for the patient. And more importantly, the maintenance now in a case like this is much easier than indirect restorations. And as I say, somewhere down the line, it might well be that this case ends up with a ceramic outcome. But for now, there's no question the material of choice is direct. We need complete clinical control, hence the injection molding technique is just cut out for this. And yeah, that was a great result for this patient. So the next case we're going to look at actually has become one of the kind of cornerstones, I'd say, of aesthetic dentistry at Enamel. And it's a concept that we're having to implement more and more, is the concept of light dentistry, as we call it in the DSD world. And what it involves is designing, aligning teeth, bleaching teeth, and then injecting. And so classically, again, wear cases that come in, like this patient came to see me. There were some alignment issues, and I think that we all know aligning teeth or trying to create an aesthetic outcome for teeth that are not aligned will definitely have a compromise on the final aesthetic outcome. So we first align the teeth, and from a functional point of view, for sure, it's going to have an easier way for us to provide the functional occlusion that's going to protect our restorations going forward. So the first process was to do the 2D design, check where the teeth needed to end up, because this is going to guide the orthodontic process. Again, we're very lucky that we're living in this era where we have all of these digital tools available for us, because again, the aligner treatment, a full digital workflow, was guided by the 2 and 3D design. Once the alignment was carried out and finished, we then moved on to the final 3D design. Again, designing with transparency. We create, and again, these 3D designs can be done in really any software. This is Nemotech. It can be done in Exocad. It can be done in 3Shape, inline they all have the ability. It's almost not possible to create these alternative models, as I say, certainly not accurately with wax. So these two models come back to us. We create the Exoclear indexes that you know all too well now. And then we go back to the patient. We would have gone through some bleaching. And in a case like this, we would have used some bleach, home bleach, just in his final tray that we made after his alignment, so his retainer tray. We bleach his teeth. And then the next process is the injection. And in the case like this, we decided only needed to do the front 6 teeth. Again, it was prepless. There's no need to prep these teeth. We just smooth them. The surface preparation is we smooth, as you can see on this picture, any rough edges that we have. I sometimes create, as you can see on this, a small bevel, about 1 millimeter, just to allow a transition of thickness of material in this area. We sandblast, we etch, we apply universal bonding, we then we etch, as you can see here. We've covered the alternative teeth with Teflon. We seat the index and we inject. It's no more simple than this. We then go to the alternate teeth, and this is a nice picture. If you can see down the bottom right, you can see the access hole was perfectly just to the buccal on the incisal area. And this allows us to visualize the extrusion of the material. You can see how little excess we have down around the gingival area. And this really allows for rapid, very simple finishing protocols. We remove this excess, because if we don't remove that excess on this first index, you won't be able to seat the second one. So we remove the excess, we finish into proximally with our 12 blades and our strips. We check the second index seats, we cover these teeth with Teflon, and we injected. And in this case, we chose an OA1 dentine, just because I was a little bit anxious of some of the colors of the teeth showing through, and we wanted to really get the best aesthetic outcome. So often I will choose to use a slightly more opaque material to maybe block out some color issues that we might have. But what really excites me is the copy and paste concept of CAD/CAM dentistry, and certainly if you're working with I think good libraries of teeth where you have beautiful shapes. And what we mean by copy and paste is that we've really borrowed the shapes of natural teeth, and again, getting away from trying to create analog shapes, which is super, super difficult. But more importantly, these pictures are not pictures that our patients judge us. I just wanted to show you the outcome of it, and the positive outcome. And you can see from the shapes, even the macro and micro texture that we get from our 3D designs. So, these mean that the finishing is rapid. I don't have to create any of the outline of the tooth. I don't have to create any macro or micro texture. I merely have to just remove the excess, remove around the gingival margins, clean into proximally, and polish. It couldn't be an easier process than the normal way that we finish direct restorations. And that was the case. And you can see completely facially driven, completely controlled by digital workflows, beautiful integration of monolithic materials, And yeah, like just a really simple, reliable process to create, which otherwise would be, yeah, I think quite difficult restorations. So again, we're borrowing natural algorithms. We've got libraries of natural teeth with beautiful macro outlines, macro, micro texture. We integrate those into our digital plan. And yeah, we have these amazing monolithic materials that certainly over the last decade have moved away from layering, be it for indirect or direct restorations. And this is the future of dentistry, in my opinion. So what I really love about injection molding is I found so many different ways that it's helped me achieve, I think, really quite complex cases and outcomes. So here was an implant case that I did with my good friend and colleague, soon to be partner, Dr. Howie Glackman. And our cases really start off the same way, whether they're restorative, whether they're ortho, whether they're implant, or whether they're multidisciplinary. This gentleman, young gentleman, came to see me. He was missing his central incisor. He had been missing it for quite some time, and we can see that there had been some problems with tooth movement, space allocation for the implant. He was looking, there'd been buccal collapse. These are classic case. He'd been without this tooth for a long time. And so the first process was really to move the teeth into the right place. Here, we chose fixed orthodontics, not aligners, just because it gave me a little bit easier control. After a relatively short course of orthodontics, he was ready to go to the planning phase, which was going to include both the restorative and the implant phases. So again, we create that 2D plan. From the 2D, we generate a 3D plan. And from the 3D plan, we're going to now create implant guides, fully guided implant guides, which are going to guide the tissue augmentation. So how it is going to be augmenting hard and soft tissue based on the final aesthetic outcome. And we all know that in implant planning these days, it's the only way, reverse engineering, we start with the end in mind. And so Howard went through the process of creating that buccal volume, the bone grafting and soft tissue that was necessary. And the patient came back to me ready for his final implant restoration. But, you know, like all cases, there are biological elements in such demanding grafting cases. And yeah, we really didn't manage to achieve the full papilla on both between the centrals and the lateral. And now we had obviously some discrepancy in the way we were going to deal with this final aesthetic outcome, and just replacing that implant crown would have been impossible to achieve the result that the patient was looking for, because I think our patients these days really are expecting the best from us all the time. So with this in mind, we went back to the lab. We took our original 3D design, and I asked the lab to just give me the ideal situation for both the central and the lateral with regards to creating symmetry in the two central incisors. And from this, the lab were able to create an STL file where they removed the implant abutment and sent me back a model with just these two areas filled in for me. Now, I could have done it in an analog way, but that, in all honesty, would have been way too complicated and taken me a lot of time and unpredictable, in all honesty. So we chose the injection molding technique, and you can see what we've done here is we've created the surface preparation of the teeth with AquaCare 29 micron aluminum oxide. You'll see that inside here, we've just syringed some light body in silicone material to hold the soft tissue so that it doesn't collapse. And then we've used some of the Zoom tissue protection that we have just to stop any tissue irritation from the injection, from the AquaCare air abrasion. Once we've cleaned the teeth, we've etched and bonded them. We place the index as simply as this, and we inject. And really, this, in all honesty, couldn't be simpler. I think it took about 10 minutes to do. We then cleaned the restorations up as we normally do. We can see with the polarized light the beautiful integration of the material to the tooth. We fitted the implant crown, and I think the outcome was really a huge improvement, and really simple, digitally driven process that really achieved otherwise quite difficult result, and certainly with an analog way would have been really impossible. Not impossible, but really difficult to achieve. So monolithic, again, materials. We used the monolithic ceramic for we used the Emax crown for the implant crown, and we used obviously our Genial universal injectable. Here we used an A1 shade universal. The patient-driven, minimally invasive approach is now the norm. You know, this is possible with amazing digital technology and the development of new materials. And really, this is what it's all about. You know, if we think in the last 5 to 10 years, all the new materials that have come on the market have really been developed specifically for CAD/CAM type dentistry, you know, digitally driven type outcomes. So whether it's direct or indirect, and monolithic materials to simplify the process and simplify the clinical and laboratory steps. Bonded transitional restoration is another big part of our more complex rehabilitations that we do. You know, not every case can go straight into definitive restorations. And you will see this case came to us. The patient required that we replaced his failing bridge. He sadly walked into a lamppost and shattered the bridge. But from what you can see, he has a lateral that is one abutment that's had 2 apicectomies, sadly, without even any orthograde root canal. So the decision was not to remove that lateral, because as we all know, once you remove 2 teeth next to each other and you place 2 implants, this is probably one of the most challenging aesthetic cases in the front of the mouth. So the decision was to really save this tooth and augment already a collapsed ridge for the central, place a single implant, and restore. So we removed the bridge. We scanned and we planned is the process that we go through. As you can see, we go again, this is the same process for simple cases, complex cases. 2D design. From the 2D design, we took him to 3D, facially driven. As you can see, always correct tooth proportions, correct incisal, facially driven decisions. And from here, we milled the ideal temporary bridge. The problem was obviously occlusion, that, as you can imagine, if we placed this bridge without doing anything to the canines, all the guidance was now on that poor lateral, which really was, as we can see, a compromised tooth. So the decision was to, while we're going through the temporary phase of augmenting, placing implants, bone grafting, to provide the patient with temporary restorations to restore aesthetics, but more important, function, and to give him guidance, canine guidance, and to protect the temporary bridge from any trauma that might have arisen. We then evaluated the shade that we had chosen, and here we used A1 universal. In all honesty, I probably could have gone for a dentine type, because of, you can see the quite dark canines and the shade that we were trying to achieve. But these are transitional restorations, so I wasn't that stressed. We then get the lab to make an SDL with that's based on the tooth preparations. As I said, if we've got indirect and a combination of direct injectable, we always do the injection molding before we fit the indirect restorations, whether they're temporary restorations or final restorations. So in a case like this, when we're doing bonded transitional restorations, what you'll notice is that I don't bother doing alternates. So I don't mind as long as we can clean interproximally at the gingival area. I don't mind if these restorations are splintered. It's not necessary to make individual restorations that are only going to be there for 3 to 6 months. As long as there's a space to clean interproximally with a little brush, this is more than adequate. So we injected, as you can see, we injected all three. We were doing from the 1-3, the 2-2, and the 2-3. We injected. We then removed. You can see the excess. We then removed the index, the Exoclear index. You can see the results. We then removed the excess, polished these, and fitted the temporary PMMA bridge, all aesthetically, functionally driven from the digital design. So again, this is really helping us that we're following the plan, it's guided, and now we have proper guidance, we have no lateral forces on the canine, and how we can then go ahead and start the grafting process and the implant patient, after which the patient comes back to me. We utilize, and you can see that we're going through the grafting process, same bridge. When eventually the implant is ready to be restored, it's then just re-scanning, and basically this case was done fully digital. We then bring back the 3D design, we overlay it onto the scan, the digital scan of the scan bodies and the prep scan, and really we end up with the final result, which again is driven from the original design. And you can see now beautiful integration, a complex case. You can see cases like this with access holds are completely driven by guided implant placement, yeah, the aesthetic outcome is important for the patient's point of view, not those intraoral pictures. But yeah, I think that this is a great case to show us how we have complete control of all the clinical aspects of the case through the temporary phase and the final restorations, through the guided bone regeneration, through implant placement, and final ceramic restorations, all following the 3D plan that was done in the original before we started the case. And so the very last case I'm going to wrap up with, and you know, each time I think that's it, there's not going to be another way I can use it. I find something else. And to be honest, I don't do a lot of removable dentistry in my practice. Sadly, I used to enjoy it, but this was a case that came to me, and the patient wasn't interested in implants. He was super happy with his chrome denture, which, as you can see, had been in his mouth a really long time. But he wasn't interested in complex dentistry. He really just wanted me to give him another removable solution. And I think this is a great opportunity for us. And so he came in, and again, you know, using full digital workflows, what we realized, and if I went back to my knowledge on all the removable chromes that I'd made, is that, you know, these teeth are far from ideal as abutment teeth because of the undercuts that they have. In fact, I mean, small undercuts are good, but undercuts like that are no good. And so if you have a look at the scan, we'll see the shape of that tooth doesn't lend itself for guide planes and clasps. So the concern was, in a normal world, we would have prepped that tooth for a ceramic restorations to create these parallel surfaces, to create the undercuts for the clasps. But thinking outside the box and having the ability to plan things digitally, I spoke with my amazing ceramist, Shane from Diceram. If he's listening, shout out to Shane. All the work you saw tonight was done by him. And, you know, I think without our technicians and the help we get from them and support, yeah, we wouldn't be able to do the job that we do and help the patients in these ways. So I asked him to create the ideal guide planes for a chrome denture, given all the parameters that we know. Here's a nice article if you want to go and read up on guide planes for retention of chrome cobalts. And then I said, once we've created these ideal guide planes, create the STL printer model and send it back to me. He wasn't quite sure what I was going to do, but because that, if you go back one, we will see that actually that design went circumferentially right around the tooth. So we sandblasted the tooth. We created an Exoclear index of it. We sandblasted it, and then we injected it from both sides. So here's, if you're injecting a palatal and a buccal surface, my advice is to create 2 access holes, not 1, because you really won't ensure that you're going to get that material to get right around the 360 of the tooth. So we created these 2 access holes. We placed the index in the mouth, as you can see. We made sure that it was seated, as you can see from the transparency of the Exoclear. I could see that it had been seated properly. And then it was a matter of just really inserting those Exoclear syringes, injecting, light curing, removing the silicone index, and you can see already the result. Almost zero cleanup, almost zero cleanup. And this is not possible with wax-ups. And I'll say it again, it's not possible with wax-ups to have this control. So all we did is we removed these injection holes where the excess where we had drilled, where we had injected, and we polished the restoration. And in honestly about 3 or 4 minutes, 5 minutes, it was looking like that. Perfect guide planes, parallel for the path of insertion that had been designed digitally for the chrome denture. And in this case, no impressions were taken. The case was scanned. As you can see, 3D, the beauty about the artificial intelligence with 3Shape is it also allows us to scan soft tissue beautifully. You can see that tissue. No impressions taken. The injection molding was done from the same design, upper and lower, and the patient came back. We fitted the chromes. And, I know that some of you might be skeptical, but I can all honesty say that I fitted the chrome and I haven't seen the patient for the follow-up, and it's been now, I think, 2 months down the line, which means that everything is fitting beautifully and it's comfortable. So we opened the vertical, we injection molded that premolar down there and created, in fact, he wanted 2 chromes, so we created 2 chromes for him. He still needs to come back and do some of these replacement resin restorations on his lower anteriors. But what a beautiful result. Super simple, complete digital workflow, and really saving me the need to prep that very difficult tooth. And if I'd prepped it, he would have ended up with very little tooth structure and most likely devitalizing the tooth and ending up with a root canal. So I'm going to wrap it up there. It was not quite. We're going to wrap it up in a minute. So why do I love injection molding? Because it takes me less time than doing direct restorations in an analog direct way. The utilization of the digital planning of the silicon indexes means that we use less time. We almost have zero waste of material and less stress. And for me, this is a really positive thing. And less stress means more productive. And really, it allows us to get more predictable results all the time. So if any of you would like to find out more about injection molding, my very good friend and partner in the composite restorations course that we run with the Style Italiana group, we're running a course in Cape Town on the 16th and 17th of July. And that's the email that you can get hold of if you would like. I think there are only a few spaces left on that course. So with that, I think I've shown you really a host of different cases of how we've utilized the technique of injection molding to really help us in the predictability using copy and paste type digital workflows with beautiful monolithic materials that really move dentistry into the era of where we have complete control of our outcomes. So with that, I'm going to actually stop my sharing, and I'm more than happy to stick around and answer any questions you might have on this super exciting topic.
Great. Thank you, Doctor.
Right,
Do you
there
have
we
a
go.
question?
Right on time, eh? 1 minute, yeah, 1 minute to go. How about that? No problem. Let me just get that off. Right, there we go.
Okay, so some of the questions. First one, what software do you use to do these planning and design?
So the planning can be done in any 3D design software. So, you know, here some of the plan was done in a software called Nemotech, which is where, which is just a design software. And if we're talking about similar design software that we'll know about in South Africa, ExoCAD, 3Shape design software, InLab software from Sirona. Any design software will allow you to do this sort of digital planning with ease, by the way. So yeah, most labs have access to a design software that will be able to go through these workflows.
Thank you. By how much would you open the bite for a full mouth reconstruction?
That's quite an easy question. I mean, I think it's often people think of the vertical dimension as a complex subject, but the amount that we open the vertical depends on the functional, the aesthetic, and the biological needs for the case. Essentially, it's driven by the aesthetic changes that we're going to make and by the material, the space for the material that we need to restore the case in a way that we're creating an additive environment rather than a tooth preparation environment. So that amount is not a definitive amount that we open all bites by 1 millimeter or 2 millimeter. Every single case is different, and the criteria that we look at in each case will be dependent on those three things. In other words, space for material, aesthetic changes, and function. In other words, guidance and occlusion.
If you add from palatal, like in the wear case, how do you blend it in better if the incisal edges are lengthened? Do you bevel the incisal or buccal surface?
Yeah, so I will try and bevel the buccal surface, not the palatal, or the buccal incisal area, so that we don't go from kind of a very thin amount of material to a very thick amount of material, that we go from where we're going from thin material to thick, that it's a gradual increase. So if you go straight from thin to thick, you're going to get a visible change in the optics of the material. But if you bevel and then you go gradually from the thin to a thicker, you're going to find a much better transition from that. And if I'm, you know, and don't forget with these, it's also possible, and I've done it in many cases, where if you find that there's a slight aesthetic issue, there's nothing to stop you, you know, taking a fine diamond, cutting back just a tiny little bit of the incisal area and just layering it with normal composite to enhance the aesthetic outcome. This is really simple because you're not changing any of the occlusal aspect of it, and you're not changing any of the aesthetic outline of the tooth. So all you're doing is just changing that transition area. But most of the time, if you understand the thicknesses, that you don't go from a thin to a thick material, that you have this gradual transition, or alternatively, you know, if you have a concern about that, then I would also consider using one of the opaque materials, as I did in one of those cases, because then you don't see anything.
Dr. Bowles, you talk about affordability. How much does it cost to do a full mouth rehabilitation?
Okay, I mean, I think everyone charges different fees, and I think that what's more helpful than say what I charge for a rehabilitation, I think, is to compare what a full mouth rehabilitation would cost with ceramic restorations versus injection molding techniques. So what I would say is that the cost to the patient and comparing digital to comparing direct versus indirect, the cost saving to the patient is about it costs them about a third of what an indirect rehabilitation would cost. So quite a big saving, for them. And I think also don't forget that there's two elements when we talk about saving. We're not just saving money, we're saving tooth structure. We're saving the patient from tooth preparation, first of all, and we're saving them from possible maintenance issues, because composite can be repaired, whereas if ceramic fails, we need to replace restorations. So I think there's that element that we have to think about when we're talking about the financial implications of indirect versus direct restorations in full mouth rehabilitations. But yeah, quite a big saving.
And then on that note, what treatment codes do you use for these restorations?
So if we're doing anterior teeth, we would charge for composite veneers. And then for posteriors, we'd charge for either a four-surface or composite onlays. I'm not sure of the codes. I'm so sorry. That's my treatment coordinator's job.
You can give us more guidance on that.
That's all right.
Okay. So you talk about facially driven. Can you elaborate more on the term? Explain what you mean by that.
Yeah, what I mean, if you think back to traditional dentistry, decisions for a full mouth rehabilitation, for instance, started with plaster models, opening vertical and occlusion, and finished with an assessment of the aesthetic outcome, which wasn't sometimes ideal. Whereas today, the process is that we start with the ideal aesthetic outcome before thinking about any of the functional changes that we need to implement in restoring the case. In other words, if you're talking about facially driven, we're talking about where is the ideal place in the face, taking into account the gums, the lips, and the face to place the patient's teeth. And so, this is what we determine by facially driven, that we're taking into account the ideal aesthetic outcome before making decisions about how we're going to do the treatment. We're good. I think we've lost our moderator. I can have a look at any of the questions. Let me have a look. Is the software for Smile Design on Android? Yeah, there's different Smile Design software available. I know that Ivoclar have one. It's called Ivo Smile, I believe. 3Shape has one on 3Shape software. I think more and more we'll be seeing these software, the design software is becoming available, for Smile Design. So yeah, there are some for Android, but the classic DSD or the new version, which is called SmileFi, is actually only available for iPhones, Macs, and iPads. Another one. Who do I contact when I want to start using Smile Design program system? So, I mean, without trying to push our courses that we run, we do a dedicated Smile Design course that really shows the whole DSD or Smile Design workflow. In other words, gathering the information, where we start the case, digitizing the case, the facial photographs, the information that we need to start making a 2D plan. So I think quite a few of the labs in South Africa, I can't go into all the labs, but quite a few of the labs in South Africa have a great understanding of Smile Design. And so I would certainly team up with a lab who understood Smile Design, who understood facially driven dentistry, who had design software to carry out, these types of digital protocols, be it for implants, restorative, injection molding, whatever it is. So yeah, I think that's kind of how I would do it. Are we back? Can you hear me?
Yes, I'm back. I did
Okay,
lose
that's
all
all
of
right.
the
I was looking
questions.
at some. It's fine. I was looking at some of the questions and going through them. So I
Okay.
have answered some of them for you.
Okay, so if you can just continue
If you
doing
want
that,
to,
I
if you
lost
want,
all
yeah.
of them.
Okay, I got them. Do you need a pressure pot? Yeah, no, you don't need a pressure pot. So there's one question there that says, do you need a pressure pot for the extra clear material? No, in my experience. I mean, the pressure pot gets rid of those tiny little bubbles you saw. But remember what I said, that those bubbles are only in the material, not on the surface of the material. You know, the key is that as long as the surface, so in other words, the surface of the silicon that you have where you're injecting into has no bubbles, there's no need for pressure pots. But if you wanted a beautiful clear index without any bubbles internally that make no difference, by all means, use a pressure pot to achieve that. Shall I carry on? Will you do injection molding in a case that is not additive, where you have to reduce tooth structure? Yeah, I think 100%. You know, if there's a reason that we find, you know, possibly that a tooth is slightly outside of that envelope of the 3D design, and that we need to do a small amount of tooth reduction, yeah, I mean, I would have no problem on that. Of course, always, if the reduction becomes excessive, it most likely is telling me that the case needs some minor orthodontic movement to move those teeth into that envelope of wherever it is we're trying to work. So yeah, a little bit of tooth structure. Of course, also bearing in mind that wherever we're relying on adhesive protocols for indirect and direct, we have to understand that the most reliable surface to bond to is enamel. So, you know, we have to be really understanding that if we are doing tooth preparation, we need to try and limit any preparation in the enamel and not remove the enamel and end up having to bond entirely to dentine or large amounts of dentine if we want you know, long-term outcomes that are stable. So another one from Jean Stranham. Good lecture, thank you. That's very kind. Say that. How do you do multi-shade injection molding? Yeah, that's not possible. I mean, you know, I have seen some clinical evidence that people inject 2 shades, but it's completely unreliable. So an alternative method is to inject and then cut back a little bit of the material and then put the index in again and inject the second material that we chose. And I assume that what we're trying to do is create like a multi-type result that we have in ceramic, where, you know, the new multi-blocks have both opacity and translucency. So that's the only way that I can think of, alternatively, just to cut back a little bit and do it freehand. So you'd have to inject, cut back, put the index on. And the problem is that when you're reseating indexes, you know, sometimes they just don't seat perfectly the second time. So I would tend to cut it back and then do it freehand if I want to do a multi-shade. Do you do the planning yourself or the lab, and how long does the planning take? So much the same. I do the 2D plan because I think that I want to be control of the aesthetic outcome. So I take control of the 2D plan, and then the lab gets my 2D plan and creates the 3D plan. And just think of the concept of the 3D plan was essentially a wax up. So, you know, traditionally our labs did our wax ups for us. So there are some dentists who used to do wax ups, but certainly, you know, if you're familiar with CAD/CAM dentistry and you have the software, it doesn't matter who does it. But for me personally, my lab can do it quicker and more effectively than I can. So I outsource that to the lab for the 3D design. Is it possible to use injection molding to make a composite crown? You mean to do a kind of indirect, a direct, indirect method? Yes and no. I mean, actually, in our advanced restorative course, we teach the technique where we make indirect, direct restorations. In other words, we take the 2 models and we We use rather a different type of composite, but you can do it with injection molding. So you would make it chair side, and I know that sounds, so you're going to make the restoration on the model, but it's with the same materials in an injection molding technique. You would cure it outside the mouth, and then you would bring it back to the mouth and cement it with flowable composite would be great, the same composite, and cement it. But again, I don't really see the value because the accuracy and the simplicity of injection molding means that we don't really need to go to the extra time and trouble to make these composite crowns outside the mouth. Boy, having group lectures in university, wow. We would enjoy having your group do a lecture at the University of Florida Comprehensive Dental. Would be my pleasure. So invite me. I didn't give my email, but get hold of Terry Sada. I'm sure they can help you. Thank you for a well-presented sharing knowledge. That's very kind. How do you prevent splitting of adjacent teeth that are being injection molded? How do you prevent splinting? Yeah, it's very simple. You know, if you look back at the two indexes, you will have noted that we've covered the teeth that we don't want the composite to bond to with Teflon. And then as a result, we can only etch and bond to the teeth that we are injecting. And so it's not possible. So even if there is a slight overflow of composite, it's not bonded to those neighboring teeth so that it doesn't splint. And then when we're going with the final index, we're then covering the already composite injected teeth with Teflon so that the new composite going through into the second mold can't bond to that composite. So it's a very simple, and it's the Teflon tape that you saw in those two types. From Dex Decanar, good friend, Mark, you're a star. That's very kind, my friend. It's very kind to say those nice things. What about secondary caries in these cases, or restoration of heavily carious teeth? Yeah, I think what about secondary decay? I mean, I think this happens with composites. So again, you know, the method of treatment would be, for me, if there was secondary decay, would be to remove the composite, remove the decay, and then depending on how big the cavity was, either just to sandblast and repair it, or to replace the whole composite restoration with a similar technique, or restoration of heavily carious teeth. Yeah, I think if we've lost a lot of tooth structure, then injection molding isn't lending itself, because this is for relatively, and I say relatively, healthy teeth, but teeth where there's been a huge amount of destruction. Yeah, I think there we need to start thinking in indirect restorations. So, you know, conventional ceramic restorations to restore the tooth back to function and form. Can you use injection molding to create composite crowns after canal therapy that can't afford indirect restorations? Yeah, I think this is a great technique, you know, and again, we teach our cases where what we would do is maybe build up the internal part of the tooth in a normal direct way in the mouth, and then the final part, so in other words, just the outer 2 millimeters, would be injection molding, because remember that when we do an injection molding technique, we have to get our light right through all the material. So I think, you know, that's why we would build up the tooth with a composite core directly in the normal way, and then the final part, we would injection mold just the outer surface to create the anatomy, the function, the occlusion that we need in complex cases where there's been quite a lot of tooth destruction. And for sure, that's a good alternative to an indirect ceramic restoration. And I think that would last, given the physical properties of this material, really a good amount of time. So that would be a semi-long-term or long-term provisional type restoration. Can you use, yeah, that's exactly that. Obviously, heavily tetracycline discolored teeth can't be done. Yeah, I think it depends on kind of the outcome. But here, you know, if we've got really discolored teeth, I would tend to use the more opaque dentine colors. And then by all means, you know, I think the beauty about injection molding is you can have a trial run. You can injection mold the teeth with no adhesion, with no bonding, which is essentially a mock-up, and visualize the aesthetic outcome. And if it's positive, you maybe only want to do one tooth. And if it's positive, then remove that composite. It'll just flick off, and then go through the process with etching, bonding, sandblasting. So you get to really visualize what can be achieved with quite discolored teeth before you do it. Is there anyone in Johannesburg who does injection molding, injection restorations you can recommend? Wow, I don't want to like get into trouble, but I think there's lots of dentists in Joburg who can do this sort of technique, I'm sure. With use of injection molding as an interim restorative treatment, when is it indicated to leave the composite on the palatal surface and use ceramic for the buccal? Yeah, I'm not a big fan of it's Violati. Francesca Violati loves the 3-step technique where she'll, create a palatal surface of composite, and then a ceramic veneer on the outside. Yeah, I think if it was me, I'm either going to do it in all ceramic. In other words, we're going to do ceramic on both sides, or we're going to do resin on both sides. I'm not going to mix the two, in all honesty. So I think, and then it depends on the age of the patient. All the things I talked about: affordability, age, invasive, minimally invasive concepts, and really what we're trying to achieve. Which sandblaster is the best for intraoral applications? I listen, again, without getting too involved, I love the AquaCare. I love AquaCare because, and I've had one for 15, 16 years, because I have option of 2 powders. And I like to use it with water, because really, if you use sandblasters without water, at the end of the day, everything in your surgery, including yourself, is covered with powder. So that's why I love AquaCare. When do you decide to go indirect smokers? Yeah, I mean, I think the polishability and the maintenance of these materials is so good, and the that the long-term stability, as we showed in the tests, is so good, that I have no problem in using these sorts of materials, even in smokers. To be honest with you, I've not had a problem with them. I think that what I didn't mention that's super important with these cases, because we all know about the oxygen inhibition layer, the layer of uncured composite that we end up with. So it's really essential. Normally, if you're doing direct restorations, you polish off that layer or when you're finishing it. But in these, because we're not removing any of the surface of it, it's absolutely essential to apply glycerine, KY jelly. Every company has a brand of gel, and to cure that final layer, so that you then get stability of that outer surface. Wow, we're going through. How long does the material take to cure in the mouth? Yeah, these are standard composites, so we're going to cure them really, and we're not doing more than 2 millimeters. We're very careful that we don't have huge thicknesses, because then you're going to run into problems. But we're going to cure them, depending on the opacity, 20 to 40 seconds. You could never overcure composite, by the way. So, if you're not sure, another 20 seconds is not going to do any harm. Does the silicone mold isolate the teeth from saliva? Yeah, it's a good question. That no, it doesn't. And I think, am I really concerned about these cases? So first of all, you'll notice that we don't do any of these cases on patients with any gingival inflammation. Okay, point 1. And I don't think we should do any dentistry on patients with gingival inflammation. The second thing is that we're not doing any subgingival bonding. So all of these are supragingival. And so controlling saliva, or controlling the moisture, is for me not been an issue. So I don't have a problem with that. Of course, if we do indirect restorations or even direct restorations where possible, I know we'd like to isolate with rubber dam. But in the 2 years that I've been using injection molding, I've not run into any evidence that moisture control has contaminated margins and created a problem. maybe a little bit off topic, but we're happy to go. Would you say intraoral scanners are more accurate than normal conventional impressions? I will tell you that there's a lot of research to show you that yes is the answer to that. And in my experience, you know, we've been scanning cases for now, I think 4 years, from single teeth to complex full mouth rehabs, implants and teeth, and the accuracy that we've found is better than with analog impressions. So we trust our scans more than we do conventional impressions. And there's a lot of research on that topic, by the way, if you want to look for it. Thank you, Cliffy, for that. That's very kind. Yes, we're looking forward to our new launch of our practice with Howard and the rest of our partners. We will make that public at some point soon. Can we use this technique for patients with bruxism? Yeah, for sure we can. You know, I think if we're doing full mouth rehabs and we're doing complex and we understand occlusion, there's no reason why these materials cannot be used for patients who have bruxism. And if we think about it, you know, the flexural strength of this material, if I remember, is about 170 megapascals. Now, let's remember that the flexural strength of feldspathic porcelain is only 100 to 110. So these materials are actually stronger than feldspathic porcelain, which we used happily in all our patients for decades. So I have no problem, as long as you understand and organize the occlusion to protect your restorations, no problem at all. And also remember, you know, if you happen to get a small chip, it's easy to repair versus a ceramic restoration, which you have to replace, mostly free of charge. Interesting that you use the number 12 blade. Is this only for interproximal finishing? I think we finished not just interproximal, but right around the gingival margin. You know, you can actually trim composite beautifully with number 12 blade. So do yourself a favor, but make sure it's a sharp one. But you'll be surprised how much composite finishing you can do with the 12 blade, and beautiful for interproximal, especially class 2s, by the way. Do you use retraction cord? No, we don't use retraction cord because all of our cases are supragingival. We're not trying to place composite subgingivally. So we don't feel the need. And in fact, if you place retraction cord, what's going to happen is you're going to distort the gingiva, and then the index won't fit because the index has been made on the shape of the gingiva without retraction cord. So I would say, please don't replace retraction cord. And that's it. We got through all of them. I hope I haven't left any out. Thank you, Howie. That's very kind of you to say such kind things about me. But anyway, that's it.
Yep,
so there we
that
go.
concludes the questions for the night then. Thank you so much, Doctor.
right.
Terry, can I leave the closing over to you?
Yes. Okay, there we go. Start video. Okay, I'd just like to say thanks to Mark for a fantastic lecture, and I think he answered all the questions pretty well. There were some questions about the codes that you use to help your patients that are on medical aid to recover some of the money. There are some very valuable codes that I was given by Dr. Klaas Visser, suggested codes. They might not work for every single medical aid, but they're very useful codes that anybody that wants to get these suggested list of medical aid codes from me can just email me at Terry, T-E-R-R-Y, .grayling or Grayling at gc.dental. Terry.grayling@gc.dental, and I'll email you the list of codes that you can use. And I'd also like to say that in conjunction with our trading partners, Henry Schein, we are offering all delegates that were registered tonight, if they'd like to order the injection molding kit, which consists of A1, A2, A3, and the Exaclear, and at a very special price, or any of the Exaclear individually, or any of the syringes individually. There's a 15% discount to anybody that's watched the webinar tonight. So thanks very much for that. And any other questions that you have for me on pricing or anything else to do with GC, please contact us, and also look at the GC websites. Remember that any of the latest GC products, if you type the name of the product into YouTube, you will see short, concise little video clips in high resolution that will explain everything to you on those products. So watch this space. We've got fantastic new cement coming up on the 1st of July, a new self-adhesive resin cement that's going to be a real game changer. Thanks very much, folks.
Thank you.
Thank you, everyone. Have a good evening.
Thank you.
Thank you.
Bye, then.
Thank you, ladies and
Bye-bye.
gentlemen. We'll end the webinar.